Welcome everyone. This video is dedicated to anyone dealing with depression or what is known as major depressive disorder, MDD. Let's start. It's normal to feel sad when you're faced with difficult life situations, such as losing your job or a relationship. Some people may say they feel depressed during these situations. Clinical depression, or what is known as major depressive disorder, is different in that it persists, particularly every day for at least 2 weeks, and involves other symptoms than just sadness alone. So, what is depression or major depressive disorder? Depression, also known as clinical depression or major depressive disorder, MDD, is a mental health condition that causes a persistently low or depressed mood and a loss of interest in activities that once brought joy. Major depressive disorder can also affect how you sleep, your appetite, and your ability to think clearly. These symptoms must be present for at least 2 weeks for a diagnosis. MDD, or major depressive disorder, is a chronic condition, but it usually occurs in episodes, which can last several weeks or months. You'll likely have more than one episode in your lifetime. This is different from persistent depression disorder, which is mild or moderate depression that lasts for at least 2 years. There are several subtypes of major depressive disorder. Some of the most common subtypes are or include seasonal affective disorder or seasonal depression, prenatal depression, and postpartum depression, and atypical depression. So seasonal affective disorder, your mood can change depending upon the seasons and the climate that you're in. And postpartum depression deals with basically after birth. Some women experience this. People with clinical depression often have other mental health conditions, such as substance use disorder, panic disorder, social anxiety disorder, obsessive compulsive disorder. And this can contribute to like a dual diagnosis. Now, major depressive disorder, and I will give you a diagnostic criteria for that. And as I'm giving you this information or different diagnostic criterias or the different things like that, try to not self-diagnose so much, because let someone in a mental health field help you do that. Sometimes we can feel or think a certain way and that we fit that description, but be careful about putting labels onto yourself, because it may not be correct. So always seek a second opinion or advice from a good mental health professional. Okay, so major depressive disorder diagnostic criteria. A, so 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either depressed mood or loss of interest or pleasure. So a depressed mood, you're just not feeling well, you don't have interest in doing things like, for example, if you go to the gym often, 3, 4 times a week, and then now you're not even wanting to do that, and that's what brought you joy, happiness, good feelings. This can be, that's an example. And do not, so when we're thinking about this depression or these episodes, sometimes they may be contributed to a medical condition. So we're not, so do not include those symptoms in that are clearly attributed to a medical condition, such as diabetes or cancer, things like that. Okay, 1, depressed mood most of the day, nearly every day, as indicated by either a subjective report. So subjective report would be myself, my subjective thinking or self-reflection of how I feel, how I've been for the past couple of weeks, how I've been compared to last year or a few months ago. Or observation made by others. So others can see that you haven't been at the gym. Where have you been? Or at work, they're like, you look like you're about to burst into tears, or they see you crying and things like that. And they see this happen more than just a few times. So those would be an observation made by others, friends, family, coworkers, for example. Okay. And so just as a side note, for children and adolescents, they can be in a more irritable mood than usual. But like I said, just instead of maybe self-diagnosing or saying, yes, my child has this, just seek professional mental help. Just seek help from a mental health provider to get a clearer diagnosis or a clearer answer that this may be something like a major depressive disorder. Number 2, marked diminished interest or pleasure in all or almost all activities most of the day, nearly every day, such as indicated by either subjective account or observation. Number 3, significant weight loss when not dieting or weight gain. So this is not attributed to a diet or purposely maybe weight gain or just there's a natural weight gain, or decreased or increased appetite nearly every day. So a decrease, you don't want to eat as much, or you're just wanting to eat a lot. You're wanting to eat a lot of different foods or candy, ice cream, just different things like that. In children, so in children, just think about their expected weight gain as they're changing through the months, 3-6 months, seeing if their weight is changing or after a year, things like that. It's children, you have to watch a little bit longer for this. Okay, number 4, insomnia. So unable to sleep, insomnia, or hypersomnia, and that is unable to stay awake. So insomnia, you're unable to sleep, you're waking up constantly, or hypersomnia is you're unable to stay awake, you're always wanting to sleep, you're always wanting to just, you don't have energy, things like that. And this is nearly every day. Okay, number 5, psychomotor agitation or retardation, nearly every day. So this has to be a consistent thing. These, what I've been mentioning, this has to be a consistent, seeing a pattern here. So this can be observed by others, and it's not merely a subjective feeling of restlessness or being slowed down. Number 6, fatigue or loss of energy nearly every day. Again, every day there's a change in you. There's a loss of energy. Number 7, feelings of worthlessness or excessive or inappropriate guilt. And this inappropriate guilt can be delusional. And this is nearly every day, and not merely self-reproach or guilt about being sick. Number 8, diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account, so by your own report, your account, or as observed by others. Number 9, recurrent thoughts of death, not just a fear of dying. Recurrent suicidal ideation without a specific plan, for committing suicide. So this right here, recurrent thoughts of death, it's not like a fear of dying. These are just thoughts of death and how to maybe free yourself from this life is something that's on the mind a lot. Something in your thoughts are popping up here and there. But this is without a specific plan. So you have suicidal ideation or thoughts, ideas, these things are coming up, but there is no plan in place. There maybe is no object to help this occur, like a gun or a rope, things like that, or a specific plan for the attempt or a specific plan for committing. So maybe this is an attempt or you have a plan, so now you're getting things in order. So this is without those things. You may have these ideas or feelings of wanting to release yourself from this life, but there's not an actual plans or you have access to something that can assist you in ending life. Okay, now we have B. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The episode is not attributed to the physiological effects of a substance, or to another medical condition. So this would be, a substance would be something like maybe methamphetamines or some type of prescription pills, maybe just different drugs. So that would be under a substance. A medical condition can be something like cancer or diabetes, things like that. Okay, now, diagnostic features. The criterion symptoms for major depressive disorder must be present nearly every day. So this keeps coming up. This has to be an everyday type of thing that you're feeling for at least about 2 weeks. But remember, it can last for more. It can last months. Okay. So the criterion symptoms for major depressive disorder must be present nearly every day to be considered present, with the exception of weight change and suicidal ideation. Depressed mood must be present for most of the day, in addition to being present nearly every day. Often insomnia or fatigue is the presenting complaint, and failure to probe for accompanying depressive symptoms will result in underdiagnosis. So sadness must be denied at first, but may be elicited through interview or inferred from facial expressions and demeanor. With individuals who focus on a somatic complaint, so a bodily complaint, clinicians must determine whether the distress from that complaint is associated with specific depressive symptoms. Fatigue and sleep disturbance are present in a high proportion of cases. So a lot of sleep disturbances are, a lot of people will talk of this. Psychomotor disturbances are much less common, but are indicative of a greater overall severity, as is the presence of delusional or near delusional guilt. So it's basically the disturbances of like psychomotor disturbances are not as common, having problems with the body and things like that, but they can be they can just mean you're at a greater level, or the severity of the major depressive disorder is at a higher level. So now it's going from the psyche, mainly predominantly the focus there. Now it's the body is starting to display what the psyche is, the type of pressures the psyche is under. The essential feature of a major depressive episode is a period of at least 2 weeks, during which there is either depressed mood or loss of interest or pleasure in nearly all activities. So this is going back and referring to what we talked about a little while ago. In children or adolescents, the mood may be irritable rather than sad. The individual must also experience at least 4 additional symptoms drawn from a list that include changes in appetite or weight, sleep, psychomotor activity, decreased energy, feelings of worthlessness or guilt, difficulty thinking, concentrating, or making decisions, or reoccurrent thoughts of death or suicidal ideation, or suicide plans or attempts, to count towards a major depressive episode. So these things need to come together to count for a clearer diagnosis of major depressive disorder. That's what it is. Now, with children, when you're thinking of this, children may, depending on the age of the child and how well they're able to express themselves, may take a little bit longer, and may parents, caregivers, or psychologists, anybody in the mental health field may need to take a little more time to accurately assess the child. Okay. The episode must be accompanied by clinical significant distress or impairment in social, occupational, or other important areas of functioning. For some individuals with milder episodes, functioning may appear to be normal, but required markedly increased effort. So may appear normal, but things may seem normal, but it's like you have to use more energy to do these things. You have to motivate yourself a little more. This can be just a milder episode or episodes. So it's important to reflect on yourself as well and see how you're doing, see how things have changed. The mood in a major depressive episode is often described by the person as down in the dumps. So someone may say this: I feel down in the dumps, or I feel low, I feel like I'm weighted, I feel like my shoulders are heavy, I feel that things are just not, the sun isn't shining as bright. So there's lots of ways they would express this to someone. In some cases, sadness may be denied at first, but many subsequent subsequently or be elicited by interview. So subsequent, you ask them more about this in an interview, and they will point out, and you can point out in the interview when you're talking to them, or if you're with a friend, you can tell them you look as if you're about to cry or things like that. In some individuals who complain of feeling blah, having no feelings, or feeling anxious, the presence of a depressed mood can be inferred from the person's facial expressions and demeanor. So there is paying attention if you're talking with someone or you're with someone, a family member, a friend, coworker. A lot of if these facial expressions are not something you see often in them, or if you see this kind of reoccur, if you've been working with them, around them for a number of years or time, and you see this, you can kind of see this like pattern where you can see these different facial expressions that are associated with being sad. So you can pick up on these, or you can see this even within yourself. Okay. Some individuals emphasize somatic complaints, that is, body aches, pains, rather than reporting feelings of sadness. Many individuals report or exhibit increased irritability, so that is persistent anger, a tendency to respond to events with exaggerated sense of frustration over minor matters, so minor things. They get very angry very easily, just very irritable. In some children and adolescents, an irritable or cranky mood may develop rather than sad or a dejected mood. This presentation should be differentiated from a pattern of irritability when frustrated. Loss of interest or pleasure is nearly always present in a major depressive disorder, at least to some degree. Individuals report feeling less interested in hobbies, as we said earlier about a gym. If your hobby is going to gym 4 times a week, things like that, and you just don't care anymore, or you have no enjoyment in the activities that you usually found very pleasurable, this can fit a criteria for major depressive disorder. Family members often notice social withdrawal or neglect of pleasurable events that you do, pleasurable things that you found interest, or the family noticed that you used to love to do. A child loved to maybe draw, and now they're not into art anymore. You don't see them drawing, creating these paintings or things like that. Okay, or a child loves playing basketball, and now the basketball's sitting in the room a lot. Okay, in some individuals, there's a significant reduction from previous levels of sexual interest or desire. So sometimes this can get into a somatic thing, which sexual desire is not merely or plainly a somatic event. It is a psychic event as well. But these levels can decrease, and you would think this would happen. This wouldn't seem unusual. It would seem unusual if you're not picking up on the depressed mood, depending on how severe it is. But if you're feeling down in the dumps, you're feeling sad, you're losing interest and pleasure, and your sexual interest would diminish. Appetite change may involve either a reduction or increase. So some people, when they have these episodes, they may eat a lot. If ice cream is their favorite thing to eat, that would be something that their go-to, or some type of food, or eating a lot more pasta. They're eating a lot more just whatever's their favorite dish. Or they can decrease. They're not eating at all. They're hardly feeling motivated to eat breakfast, to eat lunch. They're going maybe a full day without eating, and it can be things like that. Even their favorite food, they may not want to eat. Some depressed individuals report that they have to force themselves to eat. So they're having to force themselves to eat, to just, some are aware they're not feeling good in there. They're not wanting, but they feel like, okay, I got to, because I have to eat, have to be able to try to get through the day, to get through work. Others may eat and may crave specific foods. So certain things like their favorite food. Their favorite food, as I said, maybe their favorite food is some type of pasta dish. And now that's what they're craving or not craving. When appetite changes are severe in either direction, there may be significant loss or gain in weight, or in children, a failure to make expected weight gains may be noted. So there's different milestones, or children should be at a specific weight, not all the time. It depends on the child and genetics, things like that. So but if they may not make certain weight due to maybe a major depressive disorder. So sleep disturbances take the form of either difficulty sleeping or sleeping excessively. When insomnia is present, it typically takes the form of middle insomnia, waking up during the night or having difficulty returning to sleep. Or terminal insomnia, which is waking up too early and being unable to return to sleep. Initial insomnia, or difficulty falling asleep, may also occur. Individuals who present with oversleeping, which is hyperinsomnia, may experience prolonged sleep episodes at night or increased daytime sleep. Sometimes the reason that the individual seeks treatment is for the disturbed sleep. Psychomotor changes include agitation, for example, inability to sit still, pacing, hand wringing, or pulling, rubbing the skin, clothing, or other objects. Or retardation, slow speech, for example, slow speech, thinking, and body movements. Increased pause before answering, and speech that is decreased in volume, inflection, amount, or variety of content, or muteness. The psychomotor agitation or retardation must be severe enough to be observable by others. So others need to observe this. You seem different. The way you move, the way you walk, the way you're like, something's different about you. And not present merely subjective feelings. So you need to have a lot of information for this, and the help of others being able to have that information, or the client maybe telling us about how others are telling you these things, or saying this as well, to count that as a observable by others. Decreased energy, tiredness, and fatigue are common. A person may report significant fatigue without physical exertion. So they're not going to the gym, they're not working a laborious job, but they're very fatigued, they're very tired, more than normal, or more what they can report about in the past. Okay. Even the smallest task, so they seem to require a substantial amount of effort. the efficiency with which tasks are accomplished may be reduced. For example, an individual may complain that washing and dressing in the morning are exhausting and take twice as long as usual. The sense of worthlessness or guilt associated with major depressive disorder or a major depressive episode may include unrealistic negative evaluations of one's worth. Or guilt preoccupies or ruminates over minor past failings, so that there may be a unrealistic feeling of worthlessness and guilt, and evaluating oneself about life and the accomplishments or failures in life maybe a little too harsh or unrealistic when they express this to someone else. So if they're in a session with somebody or a friend or talking, the friend may feel or think like you're being really hard on yourself by saying this. Like it's a little harsh. It's excessive. Such individuals often misinterpret neutral or trivial day-to-day events as evidence of personal defects and have exaggerated sense of responsibility for untoward events. So they have the sense of worthlessness or guilt may be delusional proportions, of delusional proportions. So this exaggerated or delusional thinking that a person with major depressive disorder may have. For example, an individual who is convinced that he or she is personally responsible for world poverty. So that's a pretty clear example of someone that has delusional or excessive thoughts about events, that they're a part of that. That's the reason why there's so many people impoverished around the world. Blaming oneself for being sick and failing to meet occupational or interpersonal responsibilities as a result of the depression is very common. And unless delusional is considered sufficient to meet this criteria. Many individuals report impaired ability to think, concentrate, or make minor decisions. They may appear easily distracted or complain of memory difficulties. So there may be some they're not able to recall events clearly. So this may be also a sign. Those engaged in cognitively demanding pursuits are often unable to function. So if someone is maybe a high-level engineer or a doctor of some type, having a major depressive disorder or experiencing an episode while they're having an episode may not be able to function at a high level. So in children, there's a precipitous or abrupt drop in grades that may reflect poor concentration as well. So you can see this in your children as well. Maybe their grades, they've always received nothing less than a B, and then all of a sudden you start seeing them fail at these things they once received an A, usually always an A or nothing less than a B, things like that. In elderly individuals, so now these are elderly folks, minor difficulties may be the chief complaint and may be mistaken for early signs of dementia. When the major depressive episode is successfully treated, the memory problems often abate. So they may their memory basically comes back to normal. However, in some individuals, particularly elderly persons, a major depressive episode may sometimes be the initial presentation of a irreversible dementia. So that's one thought. Thoughts of death, suicidal ideation, or suicide attempts are common. They may range from a passive wish to not awaken in the morning, or a belief that others would be better off if the individual were dead, to transient but recurrent thoughts of committing suicide, to be a specific plan, or to a specific plan, suicide plan. More severely, suicidal individuals may put their affairs in order. So if you have a more serious thought or quest for suicide, you may put things in order, like, for example, settle your debts, maybe get a will in order, maybe see old friends you've had quarrels with and get things right with them, or you might write a lot of things down, to like notes left behind as if you're leaving this earth. Maybe you also will acquire the means or the materials or things, like, for example, a rope or a gun, to have prepared for this. And you've also chosen a date, a time to accomplish the suicide. So we need about 3 different things to really say this is more of a severe suicidal thinking or rumination of this. You have all these things in order. This is more of a severe. This is more than just a passive wish to not awaken in the morning. Motivations for suicide may include a desire to give up in the face of perceived insurmountable obstacles, an intense wish to end what is perceived as an unending and excruciatingly painful emotional state, an inability to foresee any enjoyment in life, or the wish to not be a burden to others. The resolution of such thinking may be a more meaningful measure of diminished suicide risk than denial of further plans of suicide. So the resolution of such thinking may be a more meaningful measure of diminished suicide risk than denial of further plans for suicide. Now, development and course. Major depressive disorder may first appear at any age, but the likelihood of onset increases remarkably with puberty. So it increases more as puberty arises. In America, the incidence appears to peak in the 20s, so around possible college time. However, first onset in late life is not uncommon. So just because there may be a peak we see around the 20s, that age, that does not mean it's not uncommon to be 40 years old and have this happen. The course of major depressive disorder is variable, such that some individuals rarely, if ever, experience remission. So a period of 2 or more months with no symptoms, or only 1 or 2 symptoms, to no more than to no more than a mild degree. So this would be somebody that rarely experiences it, or they experience a remission of it. So a lessening of the degree, while others experience many years with few or no symptoms between discrete episodes. So there can be times that you can go years without a major depressive episode, and then some type of event, or maybe nothing at all, happens, and then this episode reawakens in a way. Risk and prognosis factors. Researchers don't know the exact cause of clinical depression or major depressive disorder. So there isn't now, through therapeutic sessions, there can be, or talk therapy, you can find a root cause of it. Like, how did this first start, and things like that. Sometimes it may be harder. There isn't like a exact where you can say, oh, this is always how it starts. This is always how it starts to take seed and grow. There is several factors, though, that we know of, as we've been talking about through this video, that contribute to its development, including, so we will go through a few of these. We will talk about brain chemistry, we will talk about temperament, we'll talk about environmental causes, gene and physiological, and we will also talk about maybe heritability. How has this passed through from families? Okay, so let's start with brain chemistry. Okay, so there can be an imbalance of neurotransmitters, including serotonin. So there can be some how messages are sent. So we have these synapses in our brain, and sometimes the messages are not sent clearly, or they're not getting through clearly, or there's certain things like serotonin that's maybe decreased the level of it. So temperament, so neuroticism, which is negative affectivity, is a well-established risk factor for the onset of major depressive disorder, and high levels appear to render individuals more likely to develop depressive episodes in response to stressful life events. Environmental. Adverse childhood experiences, particularly when there are multiple experiences of diverse types, constitute a set of potential or potent risk factors for major depressive disorder. So having maybe a child experiences a lot of abuse growing up, or this could be physical, or this could be psychic abuse. So there could be, maybe the physical abuse is absent, but there is a lot of psychic abuse from their caregivers. And that can be a potential. The child could be at potentially risk for major depressive episodes. Okay. And stressful life events are well recognized as causes or to an abrupt episode of major depressive disorder. But the presence or absence of adverse life events near the onset of the episode does not appear to provide a useful guide to prognosis or treatment selection. Okay. Genetic and physiological. So first degree family members of individuals with major depressive disorder have a risk for major depressive disorder, have like a 2 to 4 fold higher than like risk than the general public. So genetics can play a role. You would have a, it doesn't mean you will, but there can be there's a higher chance for this to be relative risk appear to be higher for early onset and recurrent forms. Now, heritability is approximately 40%, and personality trait neuroticism accounts for a substantial portion of this genetic liability. Major depressive episodes that develop against the background of another disorder, such as substance use, drugs, anxiety, and borderline personality disorder, are among the most common of these. And the presenting depressive symptoms may obscure and delay recognition. So if there's different disorders in the background or different things like drugs, they can kind of muddy or cloud the recognition of this. Chronic or disabling medical conditions also increase risk for major depressive episodes. Such prevalent illnesses as diabetes, morbid obesity, and cardiovascular disease are often complicated by depressive episodes. And these episodes are more likely to become chronic than are depressive episodes in what we would call medically healthy individuals. So these are individuals that don't have such medical conditions as diabetes, maybe cancer, or there can be other medical conditions. So treatment of clinical depression or major depressive disorder often involves medication and psychotherapy or talk therapy. So this is a combination of this, with talk therapy being the more emphasized method or treatment. So studies show that a combination of these treatments is more effective than either one of them alone. So this depends, because medication, if it is not necessary, is good to maybe medication to get somebody to like a baseline. Sometimes medication is necessary to have someone get to that baseline, so then there can be talk, so there can be therapy, so there can be a therapeutic bond created. So because this can also be something that is a genetic issue, and there may be imbalances within the brain sending messages, things like that. There may be chemical issues going on within the body that can be treated with medication. However, talk therapy is very important and can help release things that medication cannot release. And also, after medication is able to bring the body back to a balance, homeostasis, medication can be decreased and eventually not used at all. And we can focus more on therapy and getting to the root cause, getting to understand this, getting to be aware, getting to know how to take steps or what to do when these episodes occur, or how to maybe even resolve this, strengthen our psyche. So this would be a treatment for it. And this treatment can be for adults or children as well, adolescents. So this is about major depressive disorder in this video. So I hope this helps you get a little bit of understanding, helps you maybe clear up some things on the topic. It is a good thing to not self-diagnose or put labels on ourselves, because labels, words that we attach to our psyche or that we tell our psyche, are very, extremely powerful. So we need to be cautious of this and not checking off the list as I'm this, I'm that, I'm this, I'm that, because we can be wrong sometimes. So there is a lot of self-evaluation involved in major depressive disorder, but there is also observations by others that are important as well. So just be cautious and receiving this information as well. And take care. Bye-bye.